Welcome to ESC TV. My name is Stephan Windecker from Bern, Switzerland, and I'm joined by Professor Marty Leon from Columbia University, New York, at the United States. We are here in Barcelona commemorating the 20th anniversary of transcatheter aortic valve implantation, and we will have a conversation as where TAVI will take us the next 20 years. There couldn't be a better individual to address the questions we will ask than Marty Leon, who really has impacted the field like nobody else, being involved very early on in the preclinical studies, in the very first case with Alain Gribier, and very importantly contributed immensely to the evidence that has been generated, namely by the partner trials led by yourself. Now, Marty, before turning to what the future will bring, let me ask you what has been the most impactful experience, be it in innovation, be it in data, or any other breakthrough in the field of transcatheter aortic valve implantation?
Stephan, thank you. Well, first, it's a pleasure to be at ESC. This is one of the great meetings in cardiology in the world, so to be here is always an honor. Transcatheter aortic valve implantation or replacement, whichever you choose to call it, has had, I think, a little bit more of a tortured course than many people think. It's been 20 years, but there certainly have been speed bumps. There have been exciting moments, and there have also been concerning moments. But for the most part, we've been able to achieve a trajectory where this has become an accepted and perhaps transformational therapy. And I believe for three reasons. First, we were very attentive to the technology and the technology evolution that was required to make this an acceptable technique, and the rapid evolution of technology was extremely important. Second, we were conscious that evidence needed to be gathered quickly and effectively and at a very high level to convince the clinical community that this should be an accepted therapy in certain patient cohorts. And I think the evidence has been very strong. And third, and maybe most important, is that we were able to simplify the procedure to the point that we could generalize it amongst the interventionalists that wanted to practice and treat patients. And the generalizability of TAVI, I think, has been a very important component of its success.
I couldn't agree more with you. I think one of the major strengths are really the reproducibility of the data in everyday clinical practice, and certainly what you alluded to, the facilitation of the procedure with the majority of procedures done now by transfemoral TAVI. Now, looking more towards the future, I think one of and the important topics that remain and where we still require more evidence is durability of the heart valves. And I would be interested in your perspective first. How do we assess durability? Surgeons, they had 50 years to contemplate about how to assess this, but I think there is no gold standard at this point in time. Who should assess durability? Should it be the device manufacturers? Should it be somebody else? What are your thoughts?
It's a very good question, Stephan. There's no question that the future continued evolution of this therapy into younger patients, lower risk patients, will depend on the so-called durability of the device, and which really means the bioprosthesis itself. We have gone to great lengths to develop standardized definitions that would constitute durability, and these have been published in the VARC-2 and the VARC-3 documents to be able to use echocardiographic and clinical and even CT parameters to assess the various features of valve function and valve dysfunction. So I think we now have a good template for defining durability. So far, the data that have applied similar quantitative echo-based techniques have suggested that durability seems to be reasonably good, certainly through 5 to 8 years. Much more work needs to be done. Appears to be somewhat similar to what we would expect from a surgical bioprosthesis, but much more work has to be done. And now all the studies we're doing are with 10 and longer year follow-up. And although I trust our industry sponsors to conduct many of these, I really do think that the clinical scientists are going to have to play a major role. And we're developing models using national databases and fairly interesting ways to follow patients, to be able to look at durability, long-term durability, in creative ways so we can get to some of these answers.
I'm looking forward also to TCT that takes place soon, and I'm sure we hear more about durability, perhaps also already out to 10 years. But I would agree with you, we probably don't need an US, European or Asian registry. There needs to be a consolidated effort on all parts, but it will be very important that we have reliable data. Yes. in the future. Now, another topic of interest for the community, but I know very close to your heart, is upstream or preemptive transcatheter aortic valve implantation. And I think there is plenty of evidence, robust evidence, indicating that we do as well as surgery, or even better, in patients with symptomatic severe aortic stenosis. But really the question is that early enough, or maybe even too late? So how do we address the appropriate timing of aortic valve interventions in the future?
You know, it's been very easy in aortic stenosis because everyone has relied on a simple echo measure of valve severity and the presence of symptoms to trigger what would be either an operation or a transcatheter procedure. But as we think about this, it's fairly naive that there should be a dichotomous point that would be the optimal timing, because some of the early assumptions were clearly invalid. The so-called latency period until the point of symptoms is not so latent, and patients accumulate cardiac abnormalities during that period of time. And also the specific point at which there's onset of symptoms is not so clearly defined, particularly in patients that are somewhat older. So we have challenged these things to try to look at populations to be able to see if earlier or preemptive or upstream treatment could be beneficial. So we're engaged now in 4 major clinical trials. Certainly there have been the small surgical studies that have looked at severe asymptomatic AS that suggested that early surgery would be better than clinical surveillance. There's an interesting EVOLVE study that is finishing enrollment that will be a fascinating look with biomarkers to understand if there's an at-risk, higher risk subset of asymptomatic AS. And we did the early TAVI study, which is already enrolled close to 1,000 patients, again looking at severe asymptomatic AS. And we'll learn a lot from that trial. But I'm even more intrigued at the earlier stages of AS. There's a lot of data suggesting there are many at-risk features within the subset of so-called moderate AS that put patients at risk for poor prognosis with just conventional clinical surveillance. So we are looking at this very carefully and have constructed a series of studies. And in the next few years, I think that we'll have meaningful information. What's important is, if these data suggest that we can extend the patient population, then this concept of having a less invasive transcatheter solution with very low mortality, very low secondary complications, that is not so burdensome on the healthcare system or on the patients, becomes the proper tool to be able to implement in some of these extended indications.
Yeah. No, I think these are very important considerations, and I'm looking forward to these trials that will address some of these questions. We know all these patients that said, I didn't have symptoms, but after they received the treatment, they actually experience the difference. And I think there's no doubt that we probably need to think about some screening of patients for valvular heart disease, which may be very insidious at the beginning, but is associated with major morbidity and mortality in the long run. So I think there are many things we need to address in the future. Perhaps in that context, treating earlier or considering patients for treatments earlier, one aspect that is also important is the lifetime management. So the recognition that patients may not be treated once, but that at the initial presentation we already need to disclose, well, this is a treatment that also has limitations. There may be degeneration of valves, and patients may need to be invited for a second procedure. How do you deal with this in your experience and practice? How should we approach and educate the community about this?
Well, it's what you said, Stephan. We have, as proceduralists, perhaps we have focused too much on just the index procedure. And we should focus more on access, identifying earlier patients that might benefit, and then after the procedure, how to best manage these patients. Because some of them are going to have a valve dysfunction and need second procedures, whether that's surgery or a repeat transcatheter procedure is something we're still exploring. There's no question that pharmacotherapy has been left out of the mix, and we think there's going to be a rediscovery of pharmacotherapy, both pre-treatment and post-treatment, that I think will improve outcomes. It's an area of special interest of mine. Patients have concomitant cardiovascular diseases, atrial fibrillation, coronary disease. That has to be managed for the long term in the context of AS. So we've designed a few studies that are going to begin to answer some of those questions. But I think as a practicing clinician, physician, we need to think beyond the procedure and think in both directions on how we can best manage these patients.
As you say, as invasive cardiologists, we are frequently focused just on the intervention, but I think the experience also from the field of percutaneous coronary intervention, where we learned so much about adjunctive pharmacotherapy, which in the mid and long term improves outcomes beyond the initial intervention, may be a good fertile ground to also inform future studies in the field of transcatheter aortic valve implantation. Well, our time is up. I take the opportunity to thank you for this conversation. And we have experienced an exciting journey of 20 years of transcatheter aortic valve implantation, where TAVI assumes now class 1 indication irrespective of risk. But as you alluded to, there's an equally exciting journey in front of us, and we are very much looking forward to this. Thank you very much, Marty.
Thank you, Stephan. It's been a pleasure.